Hey everyone, welcome back. My name's Alex Like, and in today's video we're going to talk about capnography, what it is, what it does, and how it can be useful to you in EMS every day. So let's get started with Capnography 101. So what is capnography? Well, capnography is a measurement of a partial pressure of carbon dioxide in your respiratory gases. Specifically, we're looking for carbon dioxide because it is a good indicator of overall metabolic process and state in your body. Now, a partial pressure means that within a complete quantity of room air, a partial pressure is a small amount of gas that makes up that total volume. In the case of carbon dioxide, generally speaking, it's going to be about 0.4% of the total mixture of room air at sea level. So the way we quantify this, the way that we measure it, is we measure it in millimeters of mercury to measure our pressure, and we're looking for normally about 35 to 45 using exhaled carbon dioxide. Obviously, the exhaled carbon dioxide is going to be slightly higher than the carbon dioxide content in room air because it's the result of metabolic waste or metabolic processes. Now, in most individuals, the reason this is important, most individuals, the difference between arterial and exhaled CO2 is negligible. So it's actually a very, very accurate indicator of metabolic use and metabolic demand. It's also useful to us in EMS in determining the severity of respiratory illnesses like asthma and watching them progress or perhaps improve, determining the effectiveness of our chest compressions during CPR, whether or not a ROSC or return of spontaneous circulation has occurred during CPR, monitoring for things like malignant hyperthermia, which is a rare but potentially fatal side effect of the administration of certain paralytic drugs or anesthetic gases. And we can also use it for judging the severity of sepsis, because again, it is an overall indicator of our body's metabolic processes and its use and excretion of carbon dioxide. The nice thing for us is now this process actually has been around in theory since the 19th century, but until very recently, when technology became good enough and small enough, it wasn't really used and it wasn't very useful. But because the technology has become very, very portable, very cheap, you should be using this for pretty much all your patients, especially your critically ill ones. It's non-invasive, it's very inexpensive now, and it's very, very reliable. When we apply capnography in the field, we usually have one of two options. We can use a special nasal cannula with a capnography reservoir that is hooked into the monitor, or we can use it in a traditional inline attached to an endotracheal tube or a supraglottic airway type of event. Either way, it's a very reliable system, and it should be used pretty much for all your critically ill patients. And you'll see why it's so important here in a few slides. After we've hooked our patient up to the capnography device, plugged it into our monitor, we're given sort of a new waveform that appears on your LifePak or your Zoll monitoring system. And this is known as a capnogram. And what a capnogram is it's a graphical representation of the measurement of exhaled CO2, so the partial pressure, plotted against time. On the y-axis, which is the vertical axis, you get your actual partial pressures, so your waveform, and then your x-axis is your time. So this is how long the waveform lasts. During the exhalation phase, when your patient is breathing out, you get a positive or an upward tick or an upward inflection of the wave along the y-axis. Once it reaches the highest point on this y-axis, we get what's known as our end tidal CO2, which means it's the end of tidal volume, so the end of the exhalation phase. And this is what we give a number value to. During the inspiratory phase, CO2 is being actively pulled away from the sensor site and you get a negative or downward wave on the y-axis. The duration of the entire respiratory phase is then plotted against or along the x-axis, the horizontal axis, and you get your time frame, basically. Now, what's important to note, though, is this is kind of confusing and backwards when you start thinking about it. The best way that I've kind of found to remember what goes where is if you were to picture your patient lying horizontally and they had a small, like, ping pong ball in their mouth. And when they exhaled, when they blew out, they pushed the ping pong ball out of their mouth. And then they push and they hold it in the air, and then it comes back down when they inhale. So that's basically what we're plotting here in the capnogram. Exhalation is a positive wave, inhalation is a negative wave. If you start thinking about it like that, it becomes a little bit easier to follow. Now, some of our normal values here. If you are a mammal who lives on Earth and breathes Earth air, the normal range for us is going to be between 35 and 45 millimeters of mercury. So this is the partial pressure of exhaled or expired CO2 that is normal for a mammalian metabolic process. This does not change based on age, based on size, based on species, as long as you're mammalian. Increased CO2 levels, or end-tidal CO2 levels, EtCO2, anything greater than 45 indicates that the patient is holding on to too much carbon dioxide, or they're hypercarbic. Decreased end-tidal CO2 levels, less than 35 millimeters of mercury, indicate that the patient is letting go or blowing off too much carbon dioxide. They are hypocarbic. Now, this can be from a variety of different things. It doesn't necessarily have to be as simple as hyper or hypoventilation, breathing too quickly or too slowly, respectively. This can be from metabolic processes going on as well, and we'll talk about different reasons why you would have hypercarbia or hypocarbia in the next few slides. Now, what's also important here is that the waveform shapes, actually looking at the actual shapes of the waves, can help you identify the severity of certain respiratory illnesses, identify the actual cause of the issue going on today, and maybe even spot a problem before it becomes too much of an issue. This is especially true in the cases of like advanced airway placement or airway management. Those have some very, very characteristic waves of their own, and I'll show you examples of all of those things later. Now, if we decide to use capnography during CPR, which you absolutely should, so capnography should absolutely be used during CPR, and there's different ways to accomplish this, but we use capnography during CPR to actually let us know how adequate our chest compressions are. Ideal capnography during CPR should be between 10 and 20 millimeters of mercury, because this actually tells us that there's enough CPR pressure, chest pressure, and thoracic pressure to circulate blood and to actually maintain very, very minimal metabolic process. So we're shooting for 10 to 12 in that case. You're not getting 10 to 12, you're falling below it. It's time to switch providers. It's time to switch compressors. If you suddenly get a very, very high number, it doesn't necessarily mean that you got really good at compressions all of a sudden, but a ROSC, or a return of spontaneous circulation, may have occurred, and this is an easy way to detect it early. So let's take a look at the normal shape of a normal waveform on capnography here, and you'll see that there's a bunch of different waves associated with it, but let's break it down here into chunks, and I'll kind of describe what each part of this process and each shape of this wave means. So during phase 1, this is where exhalation begins, and during this phase, we actually will clear the anatomical dead space within the lungs, so there's no CO2 that's present here. During phase 2, we start to get air from the alveoli that's full of carbon dioxide, well, relatively full of carbon dioxide, and this begins to reach the upper airway and it actually begins to become detectable on our end tidal CO2 monitor. During phase 3, the exhaled CO2 is beginning to reach more uniform levels, and this is why our waveform is beginning to square off. It's important to note the height of the phase 3 wave is directly correlated to cardiac output and metabolic processes occurring in the body at the time. As this phase 3 wave kind of reaches its crescendo, its peak, this is where we actually will measure an end tidal CO2 value. So again, remember our normal values here are between 35 and 45 millimeters of mercury, and this is where we would get that number from, the very top of the wave. And then the last phase is considered phase 0. This is when inspiration begins, and because our monitor only detects carbon dioxide, as we inhale, that carbon dioxide is pulled back into the alveoli. Remember, there's a small bit that is in atmospheric air, so the waveform kind of drops back down to baseline. So this is a normal shape of a capnography waveform. Let me show you an example of what a normal capnography waveform would look like when you've plugged this device, when you've plugged the nasal cannula capnography or the inline capnography into your monitor. So as you can see here, you've got a normal, good rectangular shaped capno wave. And what you'll notice is because you've got the length of the x-axis that goes across, you're also given the respiratory rate in minutes, or in breaths per minute, as well displayed as your capnography level. This is normal, this is what we'd want to see. And remember that wave as it goes upward, that's indicating expiration, so your patient is breathing out. Inspiratory waves go in a negative direction, they go down and back to the baseline. This next waveform is an example of hypercarbia, which means your patient is holding on to too much CO2. So let me show you what that looks like. Now, in this particular example, you'll notice the respiratory rate is very slow. So this would be like a bradypneic patient or a near apneic patient, because the respiratory rate is somewhere near 4 to 6. Hypoventilation or bradypnea or apnea isn't the only cause of hypercarbia. You can have metabolic causes of hypercarbia as well, which would produce a somewhat normal or even elevated respiratory rate. Examples of this would be things like hypermetabolism, so the early stages of sepsis or like a febrile illness when your body is kind of running at a much higher rate to fight an infection. It usually will produce higher levels of carbon dioxide as a result of metabolic acidosis. Another potentially concerning cause of hypercarbia suddenly would be malignant hyperthermia. Malignant hyperthermia is a genetic predisposition to, or a genetic issue with certain respiratory anesthetic gases, things that you would use in the operating room, or even certain paralytics like succinylcholine. And unfortunately, most patients don't know about this issue unless they've had some problem with anesthesia or they've had a family member have some issue with anesthesia. In the case of a malignant hyperthermia, you would see normal respiratory rate and often a controlled respiratory rate because you are ventilating the patient, because it is assumed that you've given them some kind of paralytic or anesthetic gas, and you have a sudden significant increase in exhaled or expired end tidal CO2. When this occurs, we can recognize it very quickly on our capnography, on our capnogram, and we can take corrective action. In the case of the example above, though, this is a bradypneic patient this patient is hypoventilating, or for whatever reason. This could be an opioid overdose, this could be a slew of other things. In this case, the way we would correct it is we would blow off the excess CO2 by ventilating the patient at a faster rate. Now, obviously, if they're breathing at a rate of 4, you should be ventilating them at a faster rate than 4 anyway. This next wave I want to show you is an example of hypocarbia, as in low levels of exhaled CO2. This can be brought on again by a variety of causes. As you can see in this waveform here, the respiratory rate is in the 40s, so our patient is hyperventilating, and this could be from, again, metabolic causes or psychological causes, but what you're seeing here is a marked decrease in the amount of exhaled CO2. So the waveform is the same kind of shape like a normal wave, however, it's much, much smaller. In the cases of a hyperventilation type of patient, if this is a psychological cause, it would simply involve coaching the patient. If this is brought on by something more significant like a metabolic cause, then we need to address the underlying issues. Now, hypercarbia can also be present in sepsis, so like severe multi-organ involvement type of infection, mass infection. And this is a good indicator of overall mortality. Like I talked about in the past slide, metabolic acidosis will lead to a respiratory or increase in respiratory rate, trying to blow off the CO2 in an attempt to correct blood pH. As a result, well, it's a lot harder to clear lactic acid. It's a lot easier to clear carbon dioxide from using your respiratory system. So as a result, because they are unable to clear lactic acid, they start blowing off too much CO2, and eventually the level begins to drop. When this happens, we start to see some other weird things kind of occur. If this is from like hyperventilation caused by prolonged psychological type of trauma, or even from sepsis, we start to see a couple of other cellular ions kind of shift as the blood pH increases. If this is from like a psychological type of issue, without the presence of metabolic acidosis. So if you're hyperventilating because you're having a panic attack, what we also see is the blood pH increase. And when this happens, free ionized calcium tends to bind to proteins with a higher affinity, and you lose ionized calcium in your bloodstream. And as a result, you start to develop what are known as carpopedal spasms, where your hands and feet will kind of begin to cramp up like this. And this is because of a shift in calcium. If this is the result of like a metabolic acidosis secondary to sepsis, this is your body's attempt to correct the acidosis that's occurring by inducing respiratory alkalosis. And this doesn't always work. So this is a good indicator of long-term mortality in sepsis patients. Very easy to apply. You would simply put on your nasal cannula, end-tidal CO2 with the little reservoir bleb, and you would monitor it from here. But again, same normal shaped wave, but it is a much smaller amplitude and a much higher respiratory rate in this case. Now, the next waveform that we'll talk about is the obstructive waveform. Now, the obstructive waveform is one of those things that is very, very, very reliable in determining the severity of certain respiratory illnesses. Now, in particular, are obstructive illnesses like asthma. Now, when my first exposure to end-tidal CO2 in the emergency department was about 10 years ago. Now, EMS had been on it for longer than that, as far as using capnography in the field, and they kind of gave us our introduction as ER nurses. Now, capnography has been used in the OR forever, but in the ER we had never seen it before. And I remember the day that I got my first patient where they mentioned the shape of a capnography waveform, and I didn't know what to do with that information. In fact, at the time, our monitors couldn't even plug a capnography device into them. So When the medics told me that the waveform was shark fin shaped, I had no idea what they meant. Looking back though, their recognition of a shark fin waveform is very, very sensitive to asthma. Now, asthma is an obstructive disease, which, and in particular, it's an air trapping disease, which means that you're able to get breaths in relatively effectively, but you can't get breaths out. That's why we get wheezing. So it's akin to taking a wind instrument like a flute or a piccolo, or even a recorder, if you remember back in primary school. And when you blow through that instrument without plugging any of the holes up, you get kind of a wider, more bass, deeper tone. Or no tone at all. When you blow through the instrument and you start occluding the airflow, that's when you produce pitch. So when you wheeze, it's the same kind of action that's going on there. So you're restricting airflow when it's coming out, and you're narrowing the diameter of the small airways, and in doing so, you're creating pitch. So that's why we hear wheezing when we're auscultating an asthma patient. In asthmatics, they start out with expiratory wheezing. So they breathe in, you can't really hear any difference in lung sounds, but when they breathe out, because they're air trapping, that's when you get that wheezing. Something like this. When you're hearing that, obviously that clues you in that this is an asthmatic, but we can also visualize this on capnography, and I'll show you what I mean here in a minute. The waveform that you're seeing here is a shark fin shaped, classically asthmatic, obstructive waveform. If we remember back to how this works, during our phase 3, which is when we should have that nice flat top on the top of the capnography waveform, we're getting a curve now. And this is because it's taking longer for an asthmatic to exhale completely. And when that happens, it's producing a more stunted, curved wave until it eventually reaches the apex. So that shark fin shape indicates that this patient is having a hard time fully exhaling. And we can couple that with other good clues like lung sounds, which would tell me that this patient is having an asthma attack. So it's very useful. Now, in some asthmatics, depending on the severity of the illness, you may see very, very high levels of end-tidal CO2, at least initially. But as the asthma progresses, the patient becomes more and more panicked and begins to breathe faster. And as a result, we blow off more CO2, so the levels of end-tidal CO2 tend to be slightly lower. Now, here's an example of the, mild to moderate type of asthmatic. And this is an example of a more severe asthma event. As you're seeing, the waveform is becoming more curved. And as this progresses, sometimes the inspiratory phase can be prolonged as well, and you can have a curve out on the opposite end. But traditionally, asthmatics, when they begin to wheeze, they wheeze with expiratory wheezing first, and then as the event begins to become more severe, if it's not treated, you can then develop inspiratory wheezing as well. Generally speaking, though, when we're hearing inspiratory wheezing and no expiratory wheezing, it's usually the result of a obstruction to the upper part of the airway. Or you're hearing an asthmatic that's so bad that they're not actually even moving airflow at all in the lungs. But you should hear absolutely no inspiratory sounds in the bases at that point as well. So we can kind of correlate, is this stridor versus wheezing if you're kind of on the fence, just based on that. But this is a good example of a bad obstructive waveform. As we treat this patient, as we give them bronchodilators, as we give them anticholinergics like Atrovent, this should begin to square out and become normal again, and the respiratory rate should slow down. This is ideally what we'd like to happen. But if the treatment is becoming, or if the treatment isn't working like we want it to, eventually we're going to see that level of end-tidal CO2 begin to drop and drop and drop, and the patient will eventually go into respiratory arrest. So we can actually see that happen well in advance of other diagnostic tools like SpO2. and tidal CO2 is much more sensitive to the changes in breathing rhythm and the changes in cardiac output of a patient who's suffering from a severe respiratory illness or respiratory condition. So that's why it's very important to use on any patient that you have who's asthmatic or who's critically ill. Now, what you're seeing here is an example of what you'd expect to see during CPR if you're providing good compressions. Now, you'll notice that the rate is very high. This is detected during CPR because of the chest compressions. The rate here looks to be about 100 or slightly over 100 per minute, which would indicate good compression speed. You'll notice too that the value of end tidal CO2 varies between 10 and 12, and this is because your providers may be becoming more fatigued. And this is normal as long as you're keeping it within that 10 to 12 range. If you start to drop below that, this is time to consider switching a provider off. Now in this next waveform here, you're seeing what would happen if you had achieved ROSC during a CPR event, a sudden dramatic increase of end tidal CO2, which would indicate actual perfusion and actual normal metabolic process is taking place. At that point, on the next rhythm check, now we can go ahead and check for a pulse and see if there's any sort of actual perfusing rhythm going on. And you see here as the rhythm kind of continues that it looks like they've found a pulse and now they're ventilating the patient. And those initial end tidal CO2s are going to be higher than normally what you would see for you and me, because your patient wasn't adequately breathing, adequately ventilating during that time that we were doing chest compressions. The way we accomplish measurement here during CPR is we can do this one of two ways. We can intubate the patient, which of course would then require hands off the chest, and that's really not good for the patient to pause chest compressions, because studies have shown repeatedly that chest compressions are really the most beneficial thing for the patient in cardiac arrest, so you don't want to pause those for any prolonged amount of time. The more contemporary way to measure CO2 or end tidal CO2 during CPR is to actually place a nasal cannula on their nose and make sure that the reservoir, the detector for end tidal CO2 is hanging where it should. Every time you do a chest compression, there's a small amount of expired air or exhaled air that comes out and then can be detected using the capnography. So that's what we really see more often than not in contemporary EMS systems, is the desire to not necessarily intubate right away or place a supraglottic airway right away, and to simply rely on the nasal cannula end tidal CO2 device to measure our capnography or measure our CO2 during CPR events. Alternatively, if you didn't want to intubate and you didn't want to just do the nasal cannula, you could throw a supraglottic airway in there and then use the inline attachment on top of the supraglottic to get the same kind of results. But just be aware that supraglottic airways are more prone to being dislodged during CPR events. And when that happens, you lose the ability to read capnography accurately. So I would recommend, if you're not going to intubate, to use capnography during CPR with the nasal cannula. That's just my personal opinion. The rhythm, the waveform that you're seeing here, is what's known as a Karari Cleft. Now, if you look at it, it looks like a normal capnography waveform. It's kind of rectangular. It's the right height as far as the amount of exhaled CO2 that we want. However, there's a notch in it. Now, what this means is your patient is attempting to breathe. So that downward inflection, remember, is inspiration. It's clearing of carbon dioxide, so they're breathing in. It's called a Karari Cleft because this is associated with mechanical ventilation after chemical paralysis and chemical sedation. So we call it Karari Cleft because most of our paralytics are derived from Karari plants, or at least the big ones like succinylcholine are. So this is called a Karari Cleft because you paralyze your patient, but now the paralytics are beginning to wear off and your patient is beginning to breathe on their own spontaneously. But at this point, it's not effective enough to be considered a real breath. But this is a good clue, good early indicator that more sedation or more paralysis is needed to maintain adequate compliance with ventilation. This second clip is a more severe instance of a Karari Cleft. So you're seeing the inspiratory attempt is becoming a little bit more significant. And this final clip, the Karari Cleft is even more pronounced. So we're seeing a very, very, very deep inspiratory attempt. You shouldn't really let it get to this point. So you should consider adding more sedation until you've got that nice flat round top as well. That's what we're shooting for. Let's go ahead and explore some other capnography waveforms that you may not see commonly, but if you do, it is definitely a cause for concern. These other waveforms may be the result of operator error as far as intubation attempts, or it could be indicators of a progressing illness or a progressing condition that definitely warrants a follow-up. So let's talk about some of these waves. This is a reverse waveform. Now, it looks kind of similar to a normal waveform, but remember during phase 3, we should have this be more positive, but in this case, it's going the opposite direction. Now, sometimes this is seen in patients with emphysema because of the limited surface area of alveoli. There's a lot of pre-existing lung damage that has occurred throughout this patient's lifetime. But more importantly, you can also see this in patients who are developing a pneumothorax, or they have a pneumothorax, but it's becoming more and more significant. And this is because air is now leaking into the pleural cavity, and it's slowly beginning to compress the lung tissue. So if you're seeing a patient that you're suspecting of having a pneumothorax, or perhaps a patient that you've intubated, and that's really a big one there. If you've intubated a patient, they're definitely more at risk for developing pneumothorax than a non-intubated patient because we're providing positive pressure ventilation. And if you have very fragile or friable lung tissue, it's very easy sometimes to cause a pneumothorax, and sometimes too in pediatric patients or infant patients, it's more likely that you'll cause a pneumothorax on them because of the pressures associated with ventilating. So if you're seeing this kind of reverse waveform, or you're seeing a developing reverse waveform, this is definitely something that warrants an immediate follow-up, an immediate assessment, and perhaps an immediate intervention. This waveform is concerning in a lot of ways for operator error as far as intubation. This is an irregular top, and it almost looks like you kind of squished two waves together. And in essence, it kind of is. The reason that we see this kind of irregular top, it's usually the result of a right mainstem intubation. And what that means is we've intubated too deeply. So we've placed our ET tube into the airway, and instead of being at the proper depth, we've intubated too deeply, and 9 times out of 10, that airway takes a turn into the right mainstem, and usually you're ventilating primarily the right lung. Sometimes it can go into the left mainstem, but because of the way anatomically how that bronchus splits, it's more likely to go into the right side. When this occurs, you're ventilating the right lung primarily, and what happens is you get a ventilatory wave from the right lung, but then CO2 will escape from the left lung kind of out of sync, so more passively. And when that occurs, you start to see this little uptick right there. So if you're seeing this, first thing you need to do is check your tube depth, and if it's deeper than you want, you need to consider backing that tube up or even reintubating the patient. You can also get this same shape from a leaking endotracheal tube cuff. So make sure that your ET tube cuffs are filled appropriately. Check the pressure of them. Make sure that it's filled at all. I've seen that happen where you've intubated the patient and they've forgotten to inflate the cuff. So please make sure, check all your equipment before you do this. Make sure your cuff isn't leaking to begin with. Make sure you inflate it after the fact, and make sure you intubate to the right depth. The last strange waveform we'll talk about is the pigtail. Now, right off the bat, you notice that this is a very strange looking capnography waveform. There's a little uptick at phase 3, and this is sometimes called a phase 4 wave, or the pigtail wave, just based on the way it looks. This is concerning for a couple of different reasons. This is seen in patients who are obese and sometimes in pregnant patients because of the weight of the patient's chest or their abdomen. What happens is when this patient is ventilated, the pregnant abdomen or the obese chest squeezes out a last little bit of CO2 before it comes kind of crashing down on itself, and the weight squeezes off or it closes those airways. So you see a very quick uptick in the last bit of the weight, phase 3, as the weight of the patient's chest begins to push out that last little bit, and then it stops, and we have our inspiratory phase. And you'll notice too that because you've got a little bit of air still left in the small airways, you have the phenomenon of rebreathing that's occurring. And you can see that here at the return to baseline. You'll notice that it doesn't quite return to the same baseline as before, and that's because there's still a little bit of CO2 in those small airways. Additionally, we can also see this in patients with poor lung compliance, patients who have pulmonary fibrosis, pneumonia, or pulmonary edema. In those instances, it's not being caused by the weight of the patient's body or chest or abdomen, but instead it's being caused by the inability of the lungs to completely expand as well. In the case of like fibrosis, or in the case of pneumonia or pulmonary edema, it's because there's actual fluid components within the alveoli or surrounding the alveoli. All right, everyone, thank you for watching that video. I hope you found it educational. I hope you got something out of it. And I hope that you're able to now see the reasons that we use capnography the way that we do. As always, please continue to stay safe and wash your hands, and I will see you next time. Have a good night.